Today, we have four very esteemed doctors on the panel, Dr. Pranathi Reddy, Dr. Dinesh Chirla, Dr. M. Subramanyam, and Dr. Shruthi Reddy Poddutoor. Now, before we begin with the session today, I would request all the participants to send us your questions by typing it in the discussion box so that we can address it in the Q&A round. I would now invite Dr. Pranathi Reddy to go ahead with the presentation. She's going to be sharing her insights on optimizing maternal fetal outcomes through modified antenatal care. Ma'am, please go ahead with the presentation.
Good morning, everybody. Today, in the era of COVID, as things have changed, I will be talking about how we can optimize maternal fetal outcomes through modified antenatal care. And the background to this is something that we all need to understand, because when the lockdown started, there was a lot of confusion about what can be provided and what can't be provided. And because of this, the Ministry of Health and Family Welfare actually released a document stating that sometimes when you focus only on these activities, it's important that we should build people's trust in our healthcare system, that essential healthcare services should continue to be delivered. And they drew on the experience of Ebola outbreak in 2014 and 15 and said that while that outbreak was being contained, they noticed that there were increased number of deaths caused by actually measles, malaria, HIV and AIDS. So they said that we have to pay attention to delivery of essential healthcare services, and they classified maternal and newborn and child health services as essential services. So with this background, we need to understand that antenatal care consists of two components. There's something called essential care, and there's something called emergency care. In this essential care, we have to provide essential maternal care and essential fetal care. So essential maternal care basically enables detecting common complications of pregnancy, and essential fetal care will enable screening for anomalies, growth disorders, which are all extremely time sensitive. Emergency obviously involves labor, delivery, and acute complications. All these are time sensitive. They can modify outcomes of pregnancy if delivered in a timely manner, and they definitely reduce maternal and neonatal morbidity and mortality. So what we had to do was we had to strike a balance between providing a safe and responsive antenatal care with the background of social distancing and lockdown, and also taking care of healthcare workers and the healthcare facility. And in a non-COVID facility, which is what we are at this point of time. So we looked for clinical guidance, and clinical guidance was available from FOXI, from ICMR. The Society for Fetal Medicine in India also issued guidelines, and RCOG also has issued guidelines. So this was the evidence we based it upon. And basically, to summarize what FOXI says is that it says that at this point, you should use the 12-week, 19-week, and 32 weeks as essential milestone visits and encourage telemedicine and communicate through web platforms.
Okay.
Basically, like I said, antenatal care will consist of essential care and emergency care. And this is essential maternal care where, you need to detect some common complications of pregnancy, and essential fetal care where screening for anomalies, growth disorders is important. And emergency care obviously consists of delivery, labor, and acute complications. These are all extremely time sensitive. They definitely can modify outcomes of pregnancy and will serve to reduce maternal and neonatal morbidity and mortality. So we had to strike a balance about providing a safe and responsive antenatal care in the background of social distancing and protecting healthcare workers in a non-COVID facility. So we drew our clinical guidance from FOXI, ICMR, the Society for Fetal Medicine in India, and from RCOG. And FOXI clearly stated that we need to have essential milestone visits at 12, 19, and 32 weeks and encourage telemedicine and communicate through web platforms. Similarly, the SFM also agreed upon this and spoke about essential scans. It also said that decision-making scans should be considered priority and should be scheduled, particularly with the background of growth restriction or severe preeclamptics where we need to monitor growth disorders. ICMR also stated similarly. So with this clinical guidance and some amount of, scientific evidence, we started looking for providing this. And the objectives that which we aimed to achieve was that we wanted to reduce the number of antenatal visits to the hospital, and we wanted to increase the gap between these visits. When the patient visited, we also wanted to reduce the duration of each visit and optimize the maximum into that visit. We wanted to supplement this with virtual visits and adhere to social distancing norms. And in this process, we also wanted to identify high-risk women and continue to provide surveillance for high-risk pregnancies and have protection of our healthcare workers and healthcare facility. So the strategy that we used was we first of all started strengthening our tech support. Then we defined a clear protocol for provision of antenatal services, defined what happened at each visit, prepared the hospital to optimize these services, and also prepared and protected our healthcare workers. So the first thing we approached was strengthening our tech support. And this played a huge role in optimizing our antenatal services. So we started using our web platforms to send messages to patients. We also used all these contact opportunities to educate them about COVID, social distancing, and personal hygiene. So we started putting out general advice to pregnant mothers about COVID-19, about following lockdown regulations, about personal hygiene, how to deal with anxiety. And we also used our tech support to reassure pregnant women about the availability of emergency services, because sometimes there's a lot of confusion about what is available, what is not. And it was very clear that emergency services, particularly labor and delivery, were continuing, and we ramped up our emergency services, and it was a complete consultant-led service was available round the clock so that we could optimize use of the staff also. And obviously, we provided emergency support for ectopics, early pregnancy bleeding. And this was, again, our tech support was very useful in providing this reassurance to pregnant women. And the most important role was in setting up of our video consultations. And this formed the backbone for a successful antenatal care. And I think the tech support here was really vital. So we started setting up video consultations. Since we already have a good system of antenatal care records in our hospital, the existing patients really didn't have too much difficulty in looping into this system. Then we worked towards developing a protocol for provision of antenatal care. And this was a combination of essential visits with video consultations. So what was the protocol that we developed? Again, we went back to our clinical resources. And we defined our essential milestone visits as the 12-week scan, 19-week scan, 28-week visit, and 36-week visit. This was supplemented effectively by video consultations and communication through web platforms. So this is the schedule we are following right now. The highlighted ones in red are the hospital visits, and the rest of them are all video consultations. So we've managed to reduce it to about 4 visits and a maximum of 5 through the antenatal period, starting from booking. And what happened at each visit? We wanted to maximize outcome from each visit by minimizing contact, thus protecting patients and healthcare workers. Our first booking visit for antenatal patients was a virtual consultation, where, we welcomed the patient, gave her an introduction, and a detailed antenatal history. And this is where all the structured antenatal record keeping comes into effect over here, because this can be directly linked to your EMR also. And a detailed history actually helps risk stratification at this stage. And you can also decide whether there's any need for cross consultation, particularly for patients with pre-existing medical disorders. And you could arrange a video consultation with those specialists like a physician or a diabetologist. It also serves to address immediate concerns, and you could discuss what supplements the woman should take, her lifestyle modifications and diet. This should be a fairly detailed consultation, and then we should go about arranging the next appointment. So after the doctor concludes the virtual visits, one of the things that we did was that we ensured that along with the doctor's prescription and advice, we made sure that they got information about general precautions with regard to COVID, how they should go about scheduling their next visit. if they were supposed to come to the hospital, we gave them instructions about how they should prepare coming for the hospital. What are the documents that they should carry? We asked them to limit the number of people. We said that only one person would be allowed to accompany you into the hospital premises, wear a mask, and only you will be allowed into the doctor consultation room. We also educated them about warning signs. What are the emergencies that they may encounter which may warrant a visit? And we gave them access to telephone numbers, the numbers which are relevant for them to ring before they came into the hospital. So the next visit, as per our antenatal schedule, would have been at the 12 weeks. And when the patient is expected to visit the hospital, how did we start preparing the hospital site and protecting the healthcare workers? We ensured that the hospital had a single entry point, and we also put up warning signs. And at this point of time, once the patient entered, they also signed a declaration form. Since we are a non-COVID facility, this helped us stratify patients who needed referral. And the FOGSI classifies them into infected, potentially infected, and clean. We set up a dedicated COVID clinic or a flu corner where the high-risk patients could be isolated, and we could then, decide what would be the further modality of treatment as per the government regulations in these patients. And the testing guidelines remain the same now, whatever the ICMR originally issued. And so we are testing in these people only at this point of time, and the testing still takes place in government facilities. We also followed social distancing norms when the patients came into the hospital. The entire seating arrangement in the hospital was changed so that the minimum effective distance was maintained between patients. Healthcare personnel were given advice about what they should do and what they shouldn't do. And again, the level 1 protection for healthcare personnel, which is what we are combining it between level 1 and level 2 protection. That is, all of them wear a disposable cap, a disposable mask, they wear their work uniform, and they wear latex gloves. And this is how they would look. The ultrasound scan was something that we had to think about because, as you can understand, the exposure time during the ultrasound scan is more than a regular consultation. And the Society for Fetal Medicine India has issued some guidelines, and they are displayed in the slide over here. And similarly, there is stratification of the patients into these 3 categories. We are presently seeing only the COVID negative patients. And the personal protective equipment recommendation is here. And we've also reduced everything, the couch, examination couch, and all these have been reduced to bare minimum. There are no bed sheets, no covers, because it facilitates very easy cleaning. The patient lies down and it's cleaned each time a second patient comes in. You can see that we've put a screen between the examiner and the patient so that there is minimum contact. And this is how the ultrasound room looks. Since they have a longer duration of exposure, they do wear other personal protective equipment as well, the people who are doing the scans. And at this visit, in addition to the nuchal translucency scan, all antenatal investigations are done. And at this point, what we have realized is that once this visit is done, a week later, a video consultation is arranged to discuss all the reports, because by then all the blood work will come in. So we are not increasing the visits for patients, and we are optimizing the visit by ensuring that all the investigations and scans are done at one go. And this actually forms the sentinel risk stratification point, the end of the first trimester, because we are very effectively able to classify patients, identify those requiring increased surveillance because of the screening tests that are performed at 12 weeks itself. Markers for preeclampsia and IUGR are also looked at this point. And I think as we go into future, the expanded conventional first trimester screening, incorporating glycosylated fibronectin will play big roles in antenatal care, particularly when, we are seeing large populations of women for risk stratification. And this is where we decide whether they fall into routine care or are there any high risk factors which require more frequent visits. Once this is done, again, all these reports are discussed in detail. We make our antenatal record at this point of time. And we also inform them about childbirth preparation classes and encourage them to consult via video if they have any concerns in between. Otherwise, the next appointment is only for the mid-trimester anomaly scan. Some practical issues that I think we need to discuss with the patient and we need to be very aware of at this stage is that I think it's important that we, in this background, we have to aggressively manage anemia because there will be practical difficulties with blood donations, with blood procurement. Consider evaluating serum ferritin, vitamin B12 and iron in the booking investigations itself. Aggressively deal with anemia, iron supplements. You keep a low threshold for intravenous iron therapy and aim to achieve 12.5 to 13 grams of hemoglobin because blood procurement, blood donations are going to be difficult in the future also. Sensitize patients to absolute need for home BP monitoring. Ask them to buy a BP apparatus and also sensitize them to the possible need for monitoring blood sugars if in future, you discover GDM. It's far easier if they're able to do all this at home. After the virtual consultation, once again, we send them all the documents so that we reiterate about social distancing. They know about warning signs. They have emergency phone numbers available with them. And then the next will be a video consultation after the mid-trimester anomaly scan. And at 18 to 19 weeks, they come to the hospital again. And at this week, we once again monitor for anemia. We sensitize them to the absolute need for home BP monitoring. And they finish the anomaly scan, proceed with the consultation and immunization. 25 weeks is a video consult, and we usually discuss their current health, inquire about fetal movements, encourage patients to buy a BP monitor, discuss mental well-being, and schedule their next actual visit at 28 to 30 weeks. And at this visit, again, we try to get the maximum out of this visit. They come and do a blood sampling for CBP and GCT. They do a growth scan, and these reports are made available to the consultant at the earliest. And with all these three reports, the consultant discusses with them. The objectives of this visit are to detect GDM, early onset growth restriction, combine all reports and consultations into one visit. The rest of the visits are all virtual visits except at 36 weeks. And at 36 weeks, once again, we monitor for anemia. They have a consultant visit, they discuss delivery plans, and if there's any requirement to schedule inductions of labors or cesarean sections as per obstetric indications, this is done at this point only. They again have virtual visits for fetal movements, home BP records, and general advice, and warning symptoms are again discussed with these patients. So, with our modified antenatal care in COVID negative patients, with this schedule, we have effectively reduced the number of hospital visits, increased the gap, reduced the duration of each visits, and we have followed social distancing norms and have been able to protect our healthcare workers and also provide surveillance for high-risk pregnancies. To conclude, antenatal care is deemed essential care and it needs to be provided. I mean, this holds for the future if any other pandemics come also. With a structured protocol and tech support, it is very possible to reduce number of visits. Early risk stratification strategies at 12 weeks will play an increasing role, and patient education is vital. New data, knowledge, and guidelines are constantly emerging, and we need to keep abreast to refine our recommendations in this condition. And I cannot overemphasize, particularly with regard to pregnancy and antenatal care, that we all have to look towards integrating technology into clinical care. And they'll play a key role in the future of antenatal and postnatal care. In our experience, we have found that clinical teams and patients are getting more and more comfortable using telemedicine. We see improved patient satisfaction, improved physician efficiency. And I once again reiterate the absolute need for you to follow all the rules of your local authorities and government. With this, I'll now hand over to Dr. Shruthi, who will talk about labor, delivery, and cesarean sections.
Yeah. Good morning, everyone. And now I'm going to talk about the care during labor and delivery in this suspected COVID pandemic season. So as we at Birthright Rainbow, we aim at providing high standards of care for the pregnant woman, fetus, newborn child, and new mother so that none of them is deprived of a tertiary care facility. And we are trying to maintain the same standards even in this challenging time. And I want to quote this, that change is the only constant in life, and one's ability to adapt to these changes will determine our success in life. So now what we are facing the change is the COVID condition, and we are trying to change our practices, obstetric practices, to adapt to this situation so that we come out successfully. So basically, the challenges in COVID pandemic are, one is treating the patients, and then second is protecting ourselves. So coming to the protection to our healthcare workers, as we all know, there can be a community spread, and the infection of this virus, especially we are seeing it can be there even in asymptomatic carriers, and this thing we should keep it in mind. And there are limiting testing facilities available right now in our state, and even if we are advising any test for any suspected patient, the time taken to get the results is almost like 48 hours. And by that time, our obstetric women definitely have to deliver. So all things keeping in mind, we have to do practices. So the challenges in the current scenario in our labor board, what we are trying to we are facing and trying to overcome this by maintaining, by changing certain things. One is the social distancing has to be maintained, and for this we have reduced the number of attendants, and we are limiting the staff exposure to an infected case and handling sudden emergencies because of restrictions of blood availability and other things, and the staff crunch also. We have to keep that in mind and then change our practices and accommodating muhurtams. So that's the reason. And of all the things, the last one is easy because we have said there is no muhurtam cases now, so we stopped doing those cases. And changes made in obstetric care during this season, I would like to divide that into two parts. One is which is applicable for all patients. That means we are not suspecting any COVID symptoms in that patient, but we are dealing with many pregnant women like this. And I would like to divide it in the second part, which is where we have made a protocol for a patient who is having symptoms of COVID disease. So the changes made in obstetric care during COVID season is for all patients without any symptoms of COVID disease, we have to follow certain changes to reduce the risk of transmission, reduce the stress to the doctors. Changes in the admission process is now we are implementing that, and changes in the treatment part in the obstetric care. So coming to changes in admission process requiring admission, the first thing, as Dr. Pranathi has mentioned, we have a system in place where all the patients coming in emergency also, the first thing is they have to be screened by a nurse at birthright entry. And then if the patient has COVID symptoms, the patient will be guided to the respiratory clinic, which is there adjacent to the ER. And then if once the patient is shifted there, the patient will be given a N95 mask, and then the doctor will come and then examine the patient. And if the patient needs admission where the patient cannot be shifted out because there is an emergency which have to be dealt, then the patient is admitted. That's when the code green is announced. And if by chance there is no COVID symptom in that patient, any patient, booked or unbooked cases, then the patient will be sent to the triage room, which is in the 4th floor. Previously, we were seeing all these patients in the first stage labor room. Now we are very strict that we have to see this patient in the triage room in the 4th floor. Then again, the doctor will decide whether the patient is completely a normal patient or suspected COVID. So if it is a normal patient, the patient will be shifted to the labor ward. So, and if there is any suspicion, then again, this has to be decided. Protecting our staff from risk of infection, we are implementing that all patients, their attendants and all healthcare workers in the hospital are going to wear surgical masks. No attendants will be allowed into the labor ward or in the OT. Even previously we were allowing one attendant in the labor ward, but now we are not encouraging that. And universal precautions for all delivery cases by all staff has to be maintained. And we are limiting our staff inside the delivery room for even for a normal patient also. When the patient in the delivery suite, we are actually limiting to 1 doctor and 2 nurses inside the room. And plastic sheet, we are using it as a screen and barrier. I would like to show that in a form of picture. And this is what the first picture shows, that the nurse and the doctors in the first stage labor room are going to have this kind of a protection with a cap, N95 mask, and over that a surgical mask and gloves. And if the patient is in the delivery room and then is at the time of delivery, all the staff inside the delivery room are going to wear a disposable gown with a extra the face shield and the leggings. And this is what we have started using for all patients, where we are putting a plastic sheet in between so that we are separating the from the head and side. We are trying to just having that as a barrier so that when the patient is trying to push the baby and with the Valsalva maneuver, the risk of droplet spread is less with this procedure. So we are using for this thing for all the patients, and especially for women. The women generally definitely has to wear the mask. And the changes in the treatment part, we are trying our best not to have any category 1 cesarean section where we have to do a C-section within 30 minutes of time. So we are keeping a little low threshold for cesarean section in a case of presumed fetal compromise. And we are encouraging epidural, but we are avoiding Antenatal because it can carry the increased risk of infection. And we are judiciously planning induction of labors. And we, as a policy, we started advising the patient not to wait beyond 40 weeks of gestation, because if they cross post-dated, then definitely what happens is the number of visits have to be more and the scans also have to be more. So we are not encouraging. We are explaining to the patient, and most of them are very happy to get admitted for induction of labor at 40 weeks. And we are admitting the patient because of this lockdown issues, travel restrictions and all. We are encouraging the patients to get admitted in the early labor phase rather than in active labor, so that we can augment or do something when depending upon the labor ward, how busy it is. And we made certain changes in the doctor's rota. We have 10 doctors here in this Banjara unit, but we are having at least 2 labor ward consultants. Around the clock availability is it is made sure that we are having 2 labor ward consultants available in the labor ward throughout the 24 hours. And we have designated 2 consultants to handle all the referrals, so that there is a uniformity in the accepting the cases or rejecting the cases and in the treatment part, so there is no confusion. And this is how it's going to decrease the stress to the doctors. And what are the changes which we made in obstetric care during COVID season when we are suspecting COVID symptoms in a pregnant woman? So we made a protocol, and this is based on our government instructions also. Any confirmed or any suspected COVID case which is coming to the Rainbow Hospital, which does not require any obstetric emergency treatment, will not be admitted into the hospital, even if it is our booked case. So we have to advise the patient to refer them to Gandhi Hospital or King Koti Hospital. But if any cases need a compulsory admission where you cannot ship the patient out or transfer the patient, then these two are, this case has to be informed either to me or Dr. Bhargavi, because we too are in charge of these patients, and we will decide whether the patient really needs an admission, compulsory admission or not at this point of time. And we always, I have to tell the patient attendants that once this obstetric emergency is treated, then the patient will be again shifted back to the designated hospital after the delivery as per the government instructions. So as we all know, the latest evidence, there is a limited evidence on what are the maternal and fetal risks because of this COVID infection during the antenatal period. It is evolving. So far the studies have said that the maternal complications are almost as same as it in a non-pregnant woman, but as we all know, we see that there is an altered body's immune system and the response to the viral infections in generally, which is more seen in the 3rd trimester. We have to keep that in mind. And previously in China, the studies from China said that there is no vertical transmission to the fetus, but the numbers were very small. And recently one of the publication was there, one case study publication was there, where there was a vertical transmission to the fetus because they could diagnose IgM antibody in the fetus. So there is a probable vertical transmission, but the evidence is evolving, so we have to wait for that. But as of now, the evidence says that there is no increased risk of miscarriages or preterm deliveries, or there is no evidence of teratogenic effect on the fetus. So keeping that in mind, whenever the patient is to be admitted in the hospital where we cannot ship the patient out before treating the patient, we are accepting the case, and the patient will be shifted immediately to the respiratory clinic. Patient will be given N95 mask, and with the full protection, the consultant will go and see the patient, and then immediately, if the patient requires admission, code green is announced, and code green, once it is announced, the designated staff with full protection will take the patient to the 4th floor OT isolation ward. We have completely separated this ward from our labor ward. So patient will be taken to the 4th floor OT isolation ward in lift number 1, and we have designated a lift also inform the anesthetist and the neonatologist at the same time that there is this kind of an admission, and the infection control nurse will come and take the swab from the isolation room, and the staff who is designated to monitor this patient will be inside the isolation room, will be monitoring the mother and the baby, and only one doctor is also designated to monitor this patient, and the staff who are there monitoring the patient will be inside the room. And once the patient is ready for the delivery or for the cesarean, the patient, we have planned to shift the patient to the OT only, whether it is a normal delivery or a cesarean section, so that things are under control. And the neonatal resuscitator is kept inside the OT. And we have kept a little bit of low threshold for doing a cesarean section because it is very difficult to manage a crash cesarean section in this scenario. And we have educated every staff that wearing PPE is utmost important before handling an emergency. And as we all know, there is if the patient is symptomatic and there is an active infection, the report said that there is an increased chance of CTG changes in labor in a COVID case. So continuous CTG is definitely recommended. Early decision for C-section is difficult, so to manage sudden emergencies, so it is better we take early decision. And wearing PPE is the priority. And we need to explain the same thing to the patients, that what is our limitation at this point of time, how quickly we can handle the emergencies. And labor analgesia, Dr. Subramanyam sir is going to cover that. And we are encouraging epidural can be offered even if there is a COVID infection, but avoiding Antenatal definitely is recommended. And the changes we brought in the management of labor, if it is a normal delivery, is only one obstetrician and 2 nurses will be inside the delivery room, which is in the theater, and 1 obstetrician, 1 circulating nurse, and 1 DIA will be waiting outside by chance if there is any issue. And all the persons who are inside the room will be wearing the personal protection equipment, and baby will be handed over to the nurse waiting outside the delivery room if it is this. And if we are doing it in the theater, yes, the neonatologist will be there inside the theater in the with the resuscitator. We have shifted that into the theater itself. And all the emergency drugs like Syntosanol, Methergin will be loaded and labeled at the beginning of the 2nd stage. The staff staying inside the delivery room will wear a full PPE, and patient will be wearing N95 throughout the stay. And if the patient has an infection, cut short the 2nd stage with instrumental delivery is recommended based on the evidence. And for LSES, we prefer only regional anesthesia. That is what is recommended. And 1 senior surgeon, 1 senior anesthetist inside the theater, 2 nurses, and 1 circulating nurse, and 1 technician inside the OT. And we are arranging 1 anesthetist, obstetrician, and 1 nurse, and 1 neonatologist outside the theater. But as soon as just before the delivery, the neonatologist will be coming into the theater because the resuscitator will be inside the theater. So handling preterm case scenarios, antenatal steroids, there is no documented evidence of the use of steroids in COVID-19 infection, but the evidence is evolving. And however, it is seen that glucocorticoids have been associated with an increased risk for mortality in patients with influenza and delayed viral clearance in patients. So keeping this in mind, I think we have to be very, very careful when we give steroid just as a prophylactic thing, unless you are really anticipating the delivery in the next 48 hours. Therefore, the use of steroids needs to be individualized. And coming to the tocolysis, if a woman presents in preterm labor, tocolysis is contraindicated in following the general principles if there is a systemic disease. This decision should be individualized again depending on the degree of clinical severity. And if there is a pulmonary involvement, beta-mimetic agents should be avoided because it can worsen the problem. And regarding the antibiotics, it is individualized. We are preferring azithromycin or amoxicillin clavulanic acid in these patients. It is our protocol. Once COVID is confirmed, then the treatment for COVID is started as per hospital protocol with antiviral therapy and hydroxychloroquine. And other supportive care should include rest, supplemental oxygen, and paracetamol. And we have to maintain a neutral fluid balance because the fluid balance is very important in these patients. And post-delivery, the patient will be directly shifted back to the isolation room in 4th floor, and she will remain there till she gets shifted out of the hospital. Even if she is shifted out to the different hospital also, we have to keep the patient in the isolation room in the 4th floor. So the patient admission and discharge will be from the same 4th floor isolation room. And thromboprophylaxis, we should never forget, pregnancy is a hypercoagulable state. And the recent evidence also says that COVID infection is associated with a lot of hypercoagulability. So thromboprophylaxis has to be considered post-delivery. Hydration, ambulation, and low molecular heparin we need to keep that in mind for all cases in a suspected COVID patient. Thank you. And now I hand over this to Dr. Subramanyam sir, who is going to talk about the anesthesia related issues.
Good afternoon, everybody. So I'm just going to speak on how to manage a COVID mother in the operation theatre, because Shruthi has covered how to manage labor. I just want to make a declaration. We have not had a COVID positive mother till date, but at the same time we are prepared, and we never know when we land with one patient. And India has already seen COVID positive delivered at All India Institute in early April. And I've actually spoken to the anesthesia team there, and whatever I'm saying is in sync with what they're doing. Just a thought for all of you. We've dealt with a lot of mothers with different infections like swine flu, H1N1, HIV, hepatitis. In fact, some of these are more dreadful if contracted by us, but we still seem to be very scared of this COVID. So I just want to demystify it a little bit. It's probably because of the widespread of the disease. Now 28 lakhs across the world have it, and around 2 lakhs have died so far. But if you look at the mortality rates, in Europe it is around 10 to 15%. But thankfully, if you see the bottom of the slide, in India the mortality has been 3%. And also in this 3%, which means if 100 patients are COVID positive, about 3 would succumb. And also, we all know that the elderly and with comorbidities like hypertension, diabetes have a higher chance of succumbing. So we don't really have to be very scared of this disease, but all the same, we have to take all precautions and make sure we don't get it. Otherwise, you're out of action for 2 weeks. Now, the basic challenge in a pregnant patient is to ensure that the newborn is safe, that the medical staff is safe, and that we also manage the disease in the mother post-delivery. And are there guidelines to do this? As Shruthi and Pranathi have shared earlier, though it is only 3 months since this disease has occurred in the world, because of the vast numbers, there are already guidelines. We have the FOXI, we have the RCOG, and some American guidelines as well. We've incorporated all this, and we have made guidelines for our institute about 2 weeks ago. And so this starts with, first thing, general preventive measures, which is very important, and all of us should maintain that distance from patients, hand hygiene, wearing surgical masks at all times, cleaning the surfaces, etc. And as Shruthi and Dr. Pranathi told earlier, we are not going to admit a positive case if it is elective. We are supposed to refer them to the designated government hospitals. Only in case of an emergency where it's not safe to ship the mother, like in an obstetric bleeding or impending eclampsia, we need to take care following the precautions Dr. Shruthi has mentioned earlier. And she mentioned about a code green. How it says, the security and housekeeping staff will ensure like a green corridor, all the pathway. They'll make sure that there are no patients or attenders or doctors in that path, so that nobody is exposed to this patient getting transported. And minimal staff, one nurse who was in the respiratory ward and an anesthetist who has gone to do the PAC, those two will be shifting the patient. And we've created a bed which is covered with a clear polythene sheet on all sides, which will actually limit any droplet spread going out from the patient to the surrounding places and prevent contamination of the pathway. It's important to prepare the operation room or the operation theatre. Ideally, you should have what is called a negative pressure operation theatre. This is ideally available only in isolation cubicles in the intensive care units. And our theatres normally have a laminar flow, which is a positive pressure ventilation coming from above. So we have two options. One is to turn off this air conditioning, or if you have a separate air handling unit for that theatre, then, and also if there's a HEPA filter, then you can continue to use that, and it is safe. And you should have a designated area inside the theatre where you wear the gown and an area to remove it. And an anesthesia machine and an OT should be designated for possible COVID patients, and we should keep that free so that you don't need to do the setup every time a patient is thought to be positive in the hospital. And it's important to have a bacterial filter so that the anesthesia machine is separated from the patient's possible secretions. So these are plastic sheets available in a roll, and you can use them to cover your equipment, anesthesia machine, the cautery, the suction, etc. And it can just be disposed at the end of the case. And it's important, as Dr. Shruthi mentioned, you should do the neonatal resuscitation within the operation theatre itself. But to maintain the safety for the neonate, you should maintain a distance of at least 2 meters or 6 feet from the patient's face. So this is how we have set up at the foot end and as far away, more than 6 feet in our operation theatre. And you should allocate roles, as Dr. Shruthi has mentioned. Our team, if there is a COVID positive or suspected, consists of 3 teams: the anesthesia team, the surgical team, and the nursing team. The anesthesia should have 2 people, because especially if you have to do a general anesthesia, you need a second anesthetist. You have 1 technician, and all these 3 will be in full PPE, which I shall show in the next slide. There is 1 runner outside the operation theatre who need not be in full protective equipment, but they are to ensure that you don't run out of supplies in the operation theatre, like you need blood or you need some drug which you run out of, they can hand it to you. Then the surgeon, there will be 1 surgeon and an assistant. Likewise for the nurses, there are 2. One is a scrub nurse and a circulating. And this is all people should be in the OT. You have to minimize the number of people. Now, just a quick outline of how to wear these equipment. I mean, I'm sure all of you have seen, there are many videos circulating and what all is the personal protective equipment. So what we have done to make things simple is we have labeled them as a sequence from 1 to 8. And there's a list put up there so that even for nurses or technicians, everything is in a sequence. So it goes from hand wash to leggings to gown, then the N95 mask, and then you wear the goggles. Then you can wear a face mask, a second layer on top of the N95. This is a face shield, this is a cap, and these are gloves. So just a quick word. This is a full suit which is ideally recommended. And this is a sort of a in-between, where this is a surgical gown and there is a face shield and a mask. You only don't have the full suit. One disadvantage we have seen while wearing a full suit like this is that it's very suffocating to the surgeon. And if you have to do prolonged procedures of even 1 hour without air conditioning, it's extremely uncomfortable. And I would strongly suggest, whichever of the 2 you use, that you should wear this equipment and do 1 or 2 normal cesarean sections so that you get the hang of what is good or bad and how you're able to manage with it. And one thing is, communication is very poor when you wear this full PPE. You can't talk to each other properly, and you should try to, have clear visual communication. And as I already said, possible, we should do a regional anesthesia. Because general anesthesia, you have to intubate and it increases the chance of aerosol generation. And we should try to avoid the patient from vomiting or coughing, all of which will increase the chance of aerosol production. Now, at all times, the patient should be wearing a mask, which will ensure that her droplets do not come out and contaminate the others in the operation theatre. So, as I said, spinal anesthesia is preferred. And you should do the spinal with the patient wearing the mask. And this is for all cases as well. It need not be in a COVID positive. And the patient continues to wear mask for the duration of the surgery. And there's a screen which separates the patient from the surgeon. And if you have to do a general anesthesia, 1 extra layer of protection is to have a hood to prevent aerosol spread while doing the intubation. And you can see this hood, this is an acrylic hood, and there are some holes in it to put your hand and hold the mask as well as intubate. So we are practicing in a child with a hood here. You can see I'm intubating a child, and it is possible. So if you do it for 1 or 2 normal cases, you'll get the hang of how to use it when an actual COVID positive patient comes. And as I said, it's key to minimize aerosol generation procedures. So any intubation is very high risk, and the aim is to avoid general anesthesia, which anyway we do in cesarean sections. But if you have to do it, you have to minimize the leak from the patient to the atmosphere. So you have to ensure that there is a proper seal between the mask and the face, and see that you don't use very high pressure and avoid coughing and bucking of the patient. So try to maintain deep planes. Even during extubation, you should extubate deep so that there is no coughing, and there should be a hood placed on top of the patient's head. And at the end, you have to be very careful in removing all the equipment which you have worn. And one other important aspect at this point is that the external surface of the PPE will be contaminated. So you should try to see that when you remove the equipment, that you don't touch the external surface of your gown or your goggles or other items, and they should be removed inside out. And disposal is very important. Whatever equipment we remove, we have to dispose according to the different categories of biomedical waste, which you're all aware of, and they should be adequately disposed. Now, you might have anesthetized a patient who at that point was not positive and later turns positive. So this is a question which haunts all of us. What are we supposed to do? So the guideline which we have come across is that if you had a close contact of 15 to 30 minutes at less than 6 feet distance without a mask, then you should home quarantine yourself. But if the contact was not close or you had a mask on, then you can stay on the job and check temperature twice a day. And there have been quite a few publications dealing with pregnant patients who were COVID positive, mostly coming out of China. And most of them say that the outcomes are not any worse off. You know, patients don't behave badly with spinal, and they don't have exaggerated hypotension or anything. And you can pretty much manage just like the way we normally do with the precautions we have mentioned. And if the mother turns positive and is getting sicker, then you should look at intensive care management either in your unit or shift to a designated higher center. And analgesia post-op again is very similar to what you would have done for a normal pregnant patient. And there are several studies in different journals. They've also looked at, in this British journal, they've looked at 50 cases who were anesthetized, who were all COVID positive in Wuhan. And they've seen who among the anesthesia staff contracted the coronavirus. And it is quite satisfying that if you wear the full PPE in a known positive case, the transmission is less than 1%. Thank you very much.
Good afternoon, everyone. Today I'm going to talk about what do we do to the newborns after the birth, especially born to a mother who was suspected to have COVID-19 infection or confirmed with COVID-19 infections, and especially with the breastfeeding protocol. Now, when it comes to neonates, fortunately, very few neonates have been reported to be positive. There have been 40 plus newborns with confirmed COVID-19 positive so far available in the published and unpublished literature so far. The common route of transmission, if you look at, has been dominantly postnatal transmission. It is from the mother who's COVID-19 positive through an aerosol, or coming in contact with someone like a family member who is positive, or could be a nosocomially acquired. There has been a lot of talk about vertical transmission. The two reported cases have been, the youngest one has been a newborn born to a mother who had severe COVID-19, who was tested at 16 hours of life by RT-PCR, who was positive. And this was probably the one which was reported in American Journal of Perinatology. It is suggested that there is a role of vertical transmission. And there was another case which was reported at 36 hours. And this suggests that there is possibly a role of vertical transmission, especially when we are talking about what we should do in terms of cord clamping and other things. This is important information. I think Shruthi has covered about role of antenatal steroid. No one has taken a clear stand about what we should do with antenatal steroids. The reason for preterm delivery is more related to maternal disease. If the maternal disease is getting worse and it has to be delivered, that is whatever reports we have about preterm delivery. And the concerns have been that whether the steroids will increase viremia. The RCPCH has said if the delivery is inevitable, then probably go ahead, because it definitely there is an evidence that there is a reduction in the mortality and improve in the preterm babies. But I think we need to wait for more evidence and a definitive guidelines from about antenatal steroids and preterm. But as far as magnesium sulfate is concerned, I think the guidelines are clear. If you are having a preterm delivery in a mother who is COVID-19 or suspect to COVID-19, you can go ahead and give magnesium sulfate. Now, where do we resuscitate? I think both Shruthi and Subramanyam has spoken about it. There are two schools of thought. One who are very conservative and strict about isolation. There's absolutely no chance because of the risk of aerosol generation. Would believe that keep the neonatal corner outside the delivery room or outside the operation theatre. On the second, who said you can keep in the same room, that is same in the labor room or operation theatre, but you maintain at least more than 2 meters or 6 feet distance, but keep a curtain or a polythene sheet separating both of them. So on the left side, which is a pink sheet, which is probably a lot of Chinese have followed up, they had said absolutely keep it in a separate room. And where you want to promote more of infant bonding, keep mother and baby in the same room, but you have to ensure that there is at least more than 6 feet distance between mother and baby. Now you can have you should ensure that this is a designated space, there are designated equipment, which could be a multi-channel monitor or could be a pulse oximeter. We prepared a designated kit for this baby so that in case, as has been repeatedly mentioning, you're just being prepared. And all of us could face this situation. Because if you know beforehand and there is time for you to refer them to a designated center, of course you would refer them. But sometimes what if there's a cord prolapse? What is an antepartum hemorrhage? And you do not have fetal bradycardia. You do not have much chance, but you have to deliver them. In those cases, I think you need to have a protocol in your unit about what you should do for such deliveries. And so identify definitive pulse oximeter, definitely sort of set up warmer, or in fact, some of the units would suggest, especially the American unit would suggest an isolate, which could convert into a warmer. And you need to prepare your own sort of resuscitation kit, which you use specifically for them so that there is no contamination with your other places. The next question comes, who should attend the delivery? And what sort of personal protective equipment should be used? One of the biggest challenges in the world is availability of personal protective equipment. And you have to be very conservative in using them also throughout. If it is a low risk delivery, one person attending the delivery is fine. Preferably, a senior most person attending the delivery is good because in the case there is an emergency, they can handle it. Because a junior person goes, can't handle it, then another second person goes, because it takes time for donning your personal protective equipment. So this is, and if suppose it's a high risk delivery, like there's a meconium strain like extreme preterm delivery, antepartum hemorrhage, diaphragmatic hernia, preferably 2% attending the delivery is important. Now, what sort of personal protective equipment they should wear? Because of the concerns about availability of personal protective equipment, some countries have taken a conservative approach, especially where the midwifery is very strong. They would say, let the person attending the delivery, like the pediatrician or the neonatologist, stay outside. And once the baby is born, if the baby is crying and looks fine and is not needing any respiratory support, then the midwife would get, or the nurse would get the baby out, and the person would wear a regular personal protective PPE too, like would just wear a gown, mask, and a regular mask and a goggle, and do a regular checkup, and that should be fine. But if the baby is requiring respiratory support, that is when they would sort of need an N95 mask, so that because that is where the risk of aerosol generation would be higher, and that is where the doctor or the healthcare provider should protect themselves, and that is sort of fair. But if you look at the Foxian and the NNF recommendations for our country, because in our country, because the midwifery is still not very strong, the recommendation is whoever attends delivery, the person should wear a full personal protective equipment as of attending delivery, preferably 1% for the low risk and 2% for the high risk delivery. How should be the delivery room setup? Now, if you look at the delivery room setup as shown in the picture cartoon here, we're not allowing the husband to come into the delivery. And this is one of the sort of sad part during this time. And I think a lot of time the husband used to look forward to this. If we can provide, and I think people are still trying to find a way of somehow allowing the wife to husband to interact. That is what sort of they are developing that in the US, is virtual interaction with the husband. That is what sort of this cartoon is showing. Apart from, of course, the PPE to mother, to the obstetricians, PPE to the neonatologist, and to all the staff who are there. But minimize the number of staff in the delivery room is the recommendations which we are sort of suggest, and reduce the skin-to-skin contact. Delayed cord clamping. This is the biggest controversy. If you look at the recommendations, the RCOG, the American College of Obstetrics, or the American Academy of Pediatrics have a different school of thoughts. And if you look from the Chinese recommendations and what the National Neonatology Forum and FOXI has taken, we have a different school of thought. The main reason is whether vertical transmission is happening or not. The AAP would suggest probably delay the cord clamping. But because of this, still we do not have adequate evidence about risk of vertical transmission. The NNF and the FOXI have taken the stand that let's go ahead with prompt cord clamping. We have more evidence about vertical transmission. And I would suggest to all to go ahead with prompt cord clamping till we get more evidence about it. The second recommendation is about skin-to-skin contact, which we sort of aggressively promote. Because the risk of, though it has been very clearly shown that there is no viral RNA in the sort of amniotic fluid or the vaginal secretions, but promoting sort of at this stage, because the risk of aerosol exposure, there's no sort of, we're not promoting skin-to-skin contact at this stage from both the NNF and the FOXI bodies. Some of the bodies like AP have asked for an early bath, which is not sort of suggested by the neonatal bodies, mainly because of the risk of hypothermia and also the risk of hospital-acquired infections. The rest of the NRP guidelines are very similar, both in the post and the COVID-19 infections or sort of in the regular sort of these things. But if the positive pressure ventilation is needed, a self-inflating bag and a mask may be preferred over a TP's resuscitator. As you can see that a physical barrier is like a curtain, should be there separating from the mother, and there should be at least a 2-meter distance from the mother where your resuscitation corner is there. And you could see that the neonatologist, so the pediatrician who's attending delivery, would be wearing the complete personal protective equipment, especially if you are doing a respiratory support to this child. In relation to the respiratory support, the risk of aerosol generation is limited when it comes to newborn, partly because the need for the positive pressure support in newborn is more related to neonatal reasons rather than COVID-19 reasons. Unlike in adults, where if you are providing any respiratory support, it is more because COVID-19 pneumonia. Second, the tidal volume required is very less. Based on this, the risk to the healthcare provider of contracting COVID-19 because of the positive pressure ventilation is less during the neonatal ventilation. However, what we have done is why we created one aerosol box so that it prevents aerosol sort of distribution to or exposure to the person who's intubating, so that we are kept near our any resuscitation cot. Also, there is a recommendation to use HEPA filter, both when if you are intubating or even if you are bag and masking, to ensure that there is a bacterial and viral filter is there when you are sort of giving positive pressure ventilation. We have done a trial runs also with the mannequin to ensure that the staff is well prepared just in the case, because this, when you would face such deliveries, we don't know. And it is very important that your unit goes through trial run to ensure that when you face such situations, it is not a learning experience. Because what happens is if one exposure to someone is COVID-19 positive, a lot of people go into quarantine and the whole hospital becomes sort of non-functional. The next thing comes is once post-resuscitation, some babies like preterm babies, children with asphyxia or children with respiratory distress need to be transported to the NICU. And it is advisable to transport them in a transport incubator rather than just shifting them in a crib or in a warmer. The next advice is about the breastfeeding, what you should do breastfeeding. The benefits of breastfeeding outweighs the risks associated with COVID-19 associated breastfeeding. If you look at the CDC recommendations, the breast milk provides protection against many illness and is the best source of nutrition for most infants. There are anecdotal reports of antibodies against COVID-19 in the breast milk. Though there are limited number of studies, SARS-CoV-2 has not been documented in the milk. The most of studies have come from China. They have not documented in this. However, during breastfeeding, the risk of transmission is by aerosol, which mother can produce while feeding. So this is something which we need to speak to the parents, and a shared decision can be made. Now, what do you mean by shared decision? So while directly breastfeeding, the parents have to be explained that there's a risk of aerosol transmission, and there's a little bit risk, though slight risk is there, of a newborn getting a COVID-19. If the parents prefer to give express breast milk, you need to have a dedicated breast pump for that mother. Washing hands and breast with soap and water and wearing masks while pumping is important, and cleaning all the equipment is also very important. And once expressed, there should be a designated person who is not exposed to COVID-19, should be the person who should be feeding the baby. However, if the mother prefers to directly breastfeed, they need to wear a face mask and wash hands before each feeding, and the risk of transmission to be explained to the family. Now, the NNF has come up with two scenarios which has been been explained by the American Academy of Pediatrics also. There could be one scenario where there is a limited resources of isolation, where you could have is either you have a very big epidemic-like situation, or there are facilities to isolate infected or suspected to have COVID-19 mother is not available. In those scenarios, the healthy neonate may be roomed in with the mother, and the mother baby diet must be isolated from other suspected and infected cases, and healthy uninfected mothers and neonates. And direct breastfeeding can be given, and mother should wash hands frequently, including before breastfeeding, and wear mask. However, if it is not feasible due to maternal or neonatal condition, express breast milk can be fed. If safe, early discharge to home, followed by telephonic follow-up or home visit by designated nurse may be considered. However, if isolation facility is available, or the family is more conservative and is concerned about risk of aerosol generation, in those cases, after immediate cord clamping, the neonate should be isolated from the mother. During the isolation, the healthy neonate should be preferably cared for by the family member not in contact with the mother or other suspected or proven cases. Mother can express milk after washing hands and breast and while wearing mask. The express milk can be fed to her own baby without pasteurization. And mother and baby can be roomed in once mother has been tested and declared to be clear of infection. So when can the mother directly breastfeed? Without PP can be resolved only after 2 negative SARS-CoV tests 24 hours apart and resolution of symptoms and fever. When should the neonate be tested? Here again, we do not have a definitive guidelines from ICMR at this stage, but whatever we have from the American Academy of Pediatrics and some of the other societies is, Foxy has come up with guidelines, is if you are symptomatic and you have history of exposure to contact with COVID-19 infection, you should get screened immediately. However, if you are asymptomatic, if a neonate is born to a mother with COVID-19 infection within 14 days of delivery or up to 28 days of birth, a nasopharyngeal and oropharyngeal swab, or if it's intubated tracheal aspirate should be sent. Some countries have even thought about rectal swabs. Conservatives, some who are about strict measures, they would do 2 swabs 24 and 48 hours after birth. Others would do 1 swab at 24 hours. When should the neonate be discharged? A stable neonate exposed to COVID-19 and being roomed in with their mothers may be discharged. A stable neonate in whom rooming is not possible because of the sickness in the mother and is being cared by a trained family member may be discharged from facility by 24 to 48 hours. So again, here, if the healthcare worker or someone else apart from mother is taking care, that person should continue to take care till mother is having 2 negative reports 24 hours apart and the fever or symptoms have settled down. And the child has to be tested at 2 to 3 weeks. However, if the child is going along with the mother has to continue to wear the PPE and till she gets 2 reports, negative reports of SARS-CoV-2 and her symptoms settle down. Thank you.
Thank you, Doctor. We now move to the Q&A. Dr. Pranathi, I would invite you to answer the question.
Yeah. So we'll start with questions. We are getting quite a few questions. Let me start with something very universal and general at first. So somebody has asked us about guidance with regard to proper use of N95 masks. And I'll direct this question to Dr. Dinesh because he's done the protocol for our entire unit on the proper use of N95 masks. Dinesh, could you please?
Yeah. See, now N95 masks, essentially, what you say, it is 95% of the particles are sort of in. That's the idea about the N95 mask. Wherever there is a risk of aerosol generation, that is where you have to sort of wear the N95 mask. So now, specifically, if you are talking from the obstetrics point of view, people who are attending the deliveries, anesthetists who are going to sort of intubate the child, neonatologists who are attending the delivery where unexpected, we do not know which newborn is going to sort of require resuscitation. Those who are going to be in prolonged contact with the mothers, especially when they are going to be sort of coughing and the risk of distance, they are the ones who would require N95 masks. And whereas someone who is going to just examine the child, mother, who are having any prolonged contact, there is no chance of any aerosol generating. There is risk of coughing, intubation, nebulization, non-invasive ventilation. These are not there. Triple surgical mask is enough for them.
Okay. Now there's a question with regard to HCQs. And I'll direct this to both Dr. Shruthi and Dr. Subramanyam. The question says that, what is the protocol for HCQs? I think in infected patients they mean. And is it mandatory to do an ECG prior to administering HCQs? So both of you can comment on this.
So one thing is the ECG, I think it is overrated a lot, the QT interval. Hydroxychloroquine can prolong the QT interval and cause a heart block, especially taken in combination with azathioprine. But the normal fit healthy patient, which is what a pregnant mother would normally be, I would not suspect it and I wouldn't make it mandatory. But if you want to go to ECG because it doesn't cost much.
And what is the protocol, Shruthi, for the patients that you...
This HCQ is given only if the patient is COVID positive. So they give it as a HCQ 200 milligrams 3 times a day for 10 days. That is what is the protocol given by the physician to us.
So now there's again questions regard to vertical transmission. I mean, it's been covered in the presentations, but both Dr. Dinesh and Dr. Shruthi, if you can comment, people want to know again about, what is the incidence of vertical transmission? Should we be worried about it? There are about 2 or 3 questions on this.
This vertical transmission, actually, it is like the studies which have come out from China, which had dealt with more number of cases. They said it is not there. They have not segregated any virus from the genital secretions or from the cord blood. But there are reports which Dr. Dinesh sir has already informed that it is like in 2 cases they have seen. I think the evidence is yet to come for us to say the percentage.
Yeah. So as I said, there was one case report from US at 15 hours of life. One of the units was tested positive, and then there is another unit was tested positive at 24 hours of life, and this was by RT-PCR. And there have been some studies where the IgM antibodies were positive. Based on this, there is a strong possibility that there could be a vertical transmission, is what being considered. I think we probably have to wait for more evidence to sort of confirm that. But again, sort of when it comes to operating this evidence for delayed cord clamping, a lot of people could say, okay, the child was having sort of, cord, the umbilical cord was connected for so many 9 months. So it makes a difference if you, let it go for another 1 minute. And that is the school of thought. And there is so much benefit of delayed cord clamping. So I think there's still sort of more rational and science required before we conclude. But as I mentioned, as per our NNF and Proxy Society, we have suggested a prompt cord clamping at this stage, and let us wait for the second question to see if we are going to change that.
So there's one question which I'll take on cesarean section versus normal delivery. So this is being asked very frequently. If you look at all scientific guidance which has come out, whether it is from the FOXC, ICMR or the RCOG, so all the scientific guidance says that there is no requirement for doing cesarean sections unless there is an obstetric indication. But all the data which is coming out from units, and this even the FOXC has acknowledged that whatever labor and delivery they've seen that there's an increased proportion of C-sections. And I think this is mainly people because, even as we speak, our understanding of the disease is increasing. And in this disease, one thing we can say with certainty is what was the truth for yesterday need not be the truth for today. So I think sometimes in interest of pragmatism, people are probably opting for a procedure with the definitive outcomes that which is a cesarean section, and you have control over the number of staff who are exposed and the patient exposure, the duration of exposure, as against a process which is labor and delivery, which can last for a long period of time. Multiple shifts of staff have to get exposed, and I suppose the people who've been actually dealing with these cases, and we are seeing an increased proportion of C-sections in these populations, is mainly for these reasons. While there's absolutely no, scientific guidance which says that you have to do because she's COVID positive. I think it's the process versus procedure which is taking precedence over here. And then the next question for Dr. Dinesh is, during neonatal resuscitation, should you be using a disposable ambu bag or a T-piece resuscitator?
As I mentioned in my presentation, the recommendation is to use a ambu bag over T-piece resuscitator.
Okay.
That is number one. Preferably, if you use a disposable bag, ambu bag is preferred because you can pull it off. Disinfection is easier and you can get rid of it. Having a separate resuscitation kit for COVID-19 delivery, if it happens, will be useful for you because that will avoid cross-contamination when you have other deliveries to sort of take.
So
you can use also there's a need for specifically for the neonatal HEPA filter is very small. Those types of HEPA filters are not yet available in our country. If that comes in, I think we continue with what we're doing at this stage and continue with your normal ambu bag, disposable ambu bags are preferred.
So one question to Dr. Subramanyam: what is the most preferred mode of anesthesia for these patients?
So as I already mentioned, if you can avoid general anesthesia, because maximum secretions are in the nose and mouth and throat. So if you can avoid going near the mouth and throat of a patient, it is always better. So basically, the regional anesthesia, which we anyway use for cesarean section, should be the preferred mode of anesthesia. The patient wearing a normal surgical mask, and if it is a proven case, they could probably wear an N95.
Okay. Now, I'm going to take this question. The question is, what is the stand Rainbow is taking with respect to antenatal scans? And again, I've covered this in my presentation, and always, right from the beginning, one of the things that we have realized, because we are a perinatal center and deal with a lot of fetal issues and also, growth restriction. So we've always supported the fact that the 12-week and 18-week scans should be like sentinel visits. They should not be missed. And this is also backed now by all the scientific guidance from the other bodies, because one of the things is that at your 12-week scan, lot of risk stratification can occur. You can combine this as your first visit for all your antenatal investigations, an opportunity to meet the patient, and your ultrasound scan itself will risk stratify the patients into, high risk and low risk in terms of how frequently they will require monitoring, particularly since now we are also screening for risk of preeclampsia and IUGR also. So the 12-week scan and 18-week scan are mandatory. 18 to 19-week scan, again, you realize is a very time-sensitive scan, and we have actually handled patients in whom we have, picked major anomalies and have been able to do timely interventions for them. And once they cross 20 weeks at this point of time, still, MTP law doesn't support offering terminations of pregnancies. And we are also focusing on doing a scan at 28 weeks to pick up early onset growth restriction, because again, interventions here have a useful outcome in terms of perinatal morbidity, mortality. It's also an indicator for a woman developing preeclampsia. So these 3 scans are mandatory, and I've shown you in my presentation that we are focusing a lot on providing extra personal protective equipment for the people who are performing the ultrasound scans, because their exposure time risk is more. So we've in fact designed the scan room completely differently now, and we're using a screen in between the patient and the performing doctor, and they use a little more extra personal protective equipment. At level 2, we are triaging that to be. And so let's go to the next question. Dr. Shruthi, why should all patients be examined in the triage room only?
So that by chance, if there is any patient which is missed by at one level in the birth right entry area, we can actually again take the history, and then if there is any suspicion, then we will have to shift, because these patients are not allowed to enter the labor ward complex. So there is a different pathway to go to the isolation area.
And this is a question for Dr. Subramanyam. In case of incomplete abortion needing check curettage under anesthesia, what anesthesia would you recommend?
So again, I mean, in this scenario, normally we would have done a general anesthesia probably, but here, unless, it's an emergency and there is profuse bleeding, I would still recommend either, if there is an epidural, topping it up or doing a spinal anesthesia.
Question for Dr. Dinesh. So again, this is with regard to breastfeeding. So the question is that, is the virus secreted in the milk? Does it cause neonatal diarrhea?
See, there have been limited number of studies where they actually look for the viral RNA in the breast milk, and none of the studies have found any evidence of viral RNA in the milk. So that is, the risk of transmission of COVID-19 or SARS-CoV-2 through breast milk is not there as of now based on the limited studies. As there's no evidence of sort of any diarrhea because of breast milk of COVID-19 mother feeding. So at this stage, the recommendation is the benefits of breast milk outweigh the risk of transmission. What is the risk of transmission through breastfeeding is the aerosol which mother might generate while she is breastfeeding. So you can either have an express breast milk, where mother takes all the precaution while expressing, like washing her hands, breast, and expressing it, and then some health care provider feeds that milk, or she can directly breastfeed, taking all aerosol precaution like putting the mask on, washing her hands, and breastfeeding. This is the true scenario based on the proportion of the cases are there and isolation facilities there in things. At this stage, in our place, I think, and also in our country, especially suppose we talk about, we have a different way. Some states are having lots of cases. Maybe one scenario happen that we may not have an isolation facility. There are some states where we have limited number of cases. There will be a second scenario where you say isolate them and express them. That's why both scenarios, scenario 1 and scenario 2 recommendations I have shared in my presentation.
Okay, one last question, and then I would request all of you to be prepared with some key take-home messages. So in a case of confirmed IUGR, how to reduce the number of scans? Is ultrasound scan mandatory? Again, we are dealing with a lot of these cases because, we do see a lot of patients with growth restriction. So we are trying to minimize the number of scans. And again, we are individualizing this. We assign one doctor for these patients. One doctor is in constant touch with them. They message them about fetal kick count, and it depends upon the stage at which it is. It's early onset IUGR, how aware the patient is, how well she can monitor fetal movements. And also we are very particular that they should be monitoring BP because sometimes IUGR can be a precedent for hypertension also. So we educate them about home BP monitoring. They are in constant touch with one doctor from the unit. They have a telephone number. And if we are satisfied with the way they are monitoring themselves, then we are trying to, increase the interval between scanning. But for all high-risk pregnancies, surveillance cannot be compromised too much, although we can adjust it a little bit. Would you agree, Dr. Shruthi?
Yes, ma'am. Definitely, we can actually club sometimes with the NST so that we can prolong, but it all depends again on the umbilical artery Doppler flow state.
So can we have some key take-home messages? Shall we start with Shruthi? Shruthi, what are the key take-home messages that you would?
Yeah, the personal hygiene is very important. Our protection is very important, not just us. The DIAs who are working with us also have to be well trained how to handle the waste disposal and all. And the plastic sheets are definitely helping us. And we are seeing that the risk of probably the risk of droplet contamination definitely will come down.
Yeah. And Dr. Dinesh?
Yep. I think as a doctors, COVID-19 is the biggest challenge all of us are facing in our life. And we all need to sort of be prepared for this. None of us know how long this is going to last. It might be a way of life, but we don't know next 2 months, 3 months or longer. But we all should be prepared to optimize care and provide the best care for mothers and the baby. That's what we all are trained to provide. At the same time, ensure safety of our healthcare providers, safety of those staff, safety of the doctors who are providing. So having an established protocol for your respective units, wherever you are, you could be in a tertiary facilities, you could be in a small district hospital, you could be a rural clinic, having your own facilities, because you have the asymptomatic mothers coming in, you could have someone sort of coming with crash sections. Having that protocol would actually help you to optimize care and ensuring that both mother and babies are safe, and at the same time, you and your staff are safe. Stay safe.
Dr. Subramanyam?
I think most of it has been covered. The basic thing is that any procedure, especially in operation theatres, minimal number of staff should be in the operation theatre. All should be properly equipped with protective equipment. And the sequence of donning and doffing, I think we should practice, especially as Shruthi said, for the non-doctors. Everyone should be aware how to wear these and how to remove them safely and dispose them. And avoid general anesthesia, avoid going close to the patient, maintain distancing, use regional anesthesia, and monitor the patient post-operatively for further signs of deterioration and manage along with an intensive care or physician.
Okay, and from me, I just have a few things to say. I think, having dealt with pregnancy is a very precious period in anyone's life. And it's not just that particular individual. The outcome of this pregnancy has long-lasting impact on how our society does also. So I think this is a period which is very crucial. And I think we should, make all efforts to provide antenatal care in the most structured way possible, while taking into account social distancing, lockdown regulations and everything. And that is very possible. And I think developing protocols is extremely important, because once you have a protocol in place, it's very easy for your staff to understand and practice. And there has been no other time in my life that I have appreciated having this huge teamwork in place. And it's just not doctors. As doctors, we've come together very well and worked well together. And having a team in place with this amazing tech support that we've got has really optimized our antenatal care. And I would urge all obstetricians to start incorporating technology into your healthcare practices. That is the future. Thank you.